Welcome. My name is Tony Denuzzo, and I'm with the Seeley Center on Aging on faculty, and I'm also Program Director for the East Texas Geriatric Education Center. This is a lecture series in basic gerontology and geriatrics. We've been doing this now. This is the 12th lecture in this series, and it's part of a program, Scholar of Aging program that is sponsored by the East Texas Geriatric Education Center, which is a 5-year grant that we received from HRSA. We received it in 2003, and this program is a 160-hour program designed to provide enhanced geriatric education for all health professionals of all disciplines and faculty who teach students in health professions. It's open to anyone and everyone as well, and I'm really pleased the way it's been going, and it's been a lot of fun and very educational for us. I'd like to acknowledge our partnership with the East Texas AHEC. They've been instrumental in helping us coordinate many of our programs. The session today is, as I guess it should be, being the last in our series, looking at Advance Directives, palliative care, and end-of-life care. But it really doesn't end there. We do have handouts. Okay, hopefully everybody got one. And we also have some articles on healing, curing, and treatment. There's an agenda that you can follow along. Everything should be basically in here, in your handout, that you can follow along and make notes with. This is the agenda that we'll try to keep with. I'm going to try not to take too long with the intros, but there are a few things to talk about. After this intro, we'll be having Dr. Cheryl Bayani coming up talking about Advance Directives, followed by Dr. Lee Grumbles talking about palliative care, and then Merlin Starr will be talking about spiritual care in palliative care setting. We'll have a little bit of a break at around 1:10, and I'll show you that restrooms are if needed. Okay. Help yourself to lunch. And welcome to come up anytime and during the session and help yourself there. As I said, even though this is the last lecture, we're going to try to continue what we're doing. We've had a really good response with this, and so we want to kind of keep it going. So we're trying to organize some summer lectures, ethics and elder abuse in June, and healthy behaviors in July. And these are always scheduled on the second Friday of each month from 12 to 3. My poor planning, I somehow ended up having this last one on the Friday the 13th. But I'm not worried about that. I'm not even going to mention it. Too late. We had learning objectives set up for these. The first 4 will be for the Advanced Directive talk. The next 3 on palliative care, and then the final 2 will be on spirituality and care and end-of-life care. As I said, this is a last one in a lecture of 12 lectures that we've had previously. And we also have a lot of information about our Scholar of Aging program on our website. And I want to also say that this is only a small part, this lecture series is a small part of our Scholar of Aging program. If you go to our website, you'll see that we have activities that go on for each month. From June through May. For example, in May we have these activities that include modules, case studies. We have some tapes and things that you could also look at. Right now we have 1 module on palliative care. We're in the process of developing 2 others that should be online very soon on ethical issues of care and living, bereavement, and grief, okay, and end-of-life issues. Okay, so take a look at that if you're interested in any of the materials. We also have several resources. There's lots of information out there on end-of-life issues and information about dealing with palliative care issues as well as advanced directives. Take a look at those if you'd like. We have this teleconference to 5 other sites throughout East Texas as part of the AHEC network that we work with. Lamar University in Beaumont, Stephen F. Austin State University in Nacogdoches, Sam Houston State University in Huntsville, and University of Texas Health Center in Tyler, and then McLennan Community College in Waco. And some of them are trying to get online. We see some, let's see if I can do this. There. What we can see here, I'll try to move that out of the way in a minute, but this is Lamar University here, and that's Stephen F. Austin there. Behind this little black area is a network of that we do on the same signal, and sometimes we don't see them unless they're voice activated. But in there you would eventually maybe see McLennan Community College, Sam Houston State, as well as Tyler. Since this is the last one, I just want to give a real quick thank you to some people that have helped put this all together. Dr. James Goodwin, who's the Medical Director for Geriatrics, is the principal investigator for the East Texas Geriatric Education Center. Obviously, without him, we wouldn't be able to do many of the things that we do here. But I'd really like to thank also Beth Schilling, whose help has been invaluable as our administrative assistant here in geriatrics. We have a program committee who have been just super in getting us information and helping steering how we want to get this done and make it successful. As well, we have people who take care of evaluation parts as well as website design. Okay. It takes too long to go through everyone, but I would like to just really acknowledge them. And also I'd like to acknowledge at each of our sites we have an AHEC coordinator and someone who basically facilitates and helps move things along, takes care of some of the logistics out there. Dr. Kelly Buchanan over in Lamar, she's with Coastal AHEC. We've had 3 coordinators over in Piney Woods AHEC, Sylvia Baker, Kelly Floyd, and presently we have Kinney Parker. She's over at Stephen F. Austin State University in Nacogdoches. Dr. Alessandro Bonanno is with Sam Houston State University in Huntsville. Linda Smith is with Lake Country AHEC, and she's over at UT Health Center in Tyler. And finally, Jason Higginbotham and Jill Stubber is with Brazos AHEC, and they're over at McLennan Community College. So it's really valuable having them there, because then we know what we're doing, what the things that we'll get back will be correct, because there's a lot of things that we're trying to get done. Also over at Lamar University in Beaumont, I'd like to thank Eileen Dedges-Curl, who's the chair of School of Nursing there. She's helped a lot in getting the School of Nursing involved in our program, as well as Dr. Peter Simby, who's the chair of social work at Stephen F. Austin State University. We are offering lots of CE credits for this of different types. There are evaluation forms for each type of credit, and if you have any questions in terms of how to do this, some of this will be outlined in your packet. For CME, 2.75 credit hours is awarded to this session, this 3-hour session, and that's for MDs, DOs, nurse practitioners, and PAs. You can contact the CME office if you have any questions about how some of the information. We're offering 3.2 credit hours, type 1 for continuing nursing education for RNs. LVNs will give them a certificate of attendance as well. And this is for up to 3.2 hours. You don't need to stay the entire 3 hours to get the credit. CEUs for social workers, we have 0.3 hours available. And finally, 3 contact hours for physical therapists and occupational therapists. All right, let's get into the program. All right, it's my pleasure to introduce Dr. Cheryl Valiani. She's well known on campus for her work on Advance Directives, living wills, just getting all those documents and that crucial information out there for the health professionals. Really valuable role that she plays as a clinical ethicist. And she's a little bio in there. She's currently assistant professor with the Institute of Medical Humanities and, as I said, a clinical ethicist in institutional ethics service at UTMB, and she's involved in clinical consultation, teaching, and institutional ethics committee. She received a doctorate in medical humanities at UTMB in 1998 and was recognized with the Dean's Award for Academic Excellence. Her research concerned anencephalic? Ooh, wow, what do you know? Anencephalic infants and use of their organs for transplantation. She then completed a postdoctoral fellowship in clinical ethics at UTMB, and she earned her BSN in nursing from the University of Virginia in '72 and an MSN in maternal care, child health nursing from the University of Texas Health Science Center at San Antonio in '78. Her topic is the nuts and bolts of Advance Directives.
Thank you very much. I'm glad to be here and talk to you about what I consider a very important topic with a lot that has been going on in our nation. I don't think anyone who can read or hear has missed the name of Terry Schiavo over the past months. And so I think there's been brought a great deal of attention to this topic, and hopefully I can provide a little more information for you and talk about some particular issues about not only for ourselves, but for society and for our patients. And so I will start with the opening statement about the nature of suffering and the goals of medicine. Eric Cassell says that the relief of suffering and the cure of disease must be seen as twin obligations of the medical profession that is truly dedicated to the care of the sick. Physicians' failure to understand the nature of suffering can result in medical intervention that, though technically adequate, not only fails to relieve suffering, but becomes a source of suffering itself. And as we think of that issue, we'll go through some of the objectives here. And some of them I'm going to cover more quickly because some of my colleagues on the podium here will talk about them. But we're going to talk about death and dying first of all, then we're going to talk about the process of advanced care planning, and then we're going to really actualize that in a case study. What are the good things? What are the bad things? What happens sometimes? Not all of us get married, get diabetes, have children. But as much as we may not like to think about it, we all are going to die. We haven't found a way to prevent that yet, and we usually have no idea about when that's going to be. I'd ask you, and we're not going to spend a little time on this, but I'll ask you sometime to think about it. Consider for yourself, what is the most wonderful death you could have? As long as we have to die, how can it be the best experience? Where do you want to be? Who do you want to be around you? How do you want to feel? What should it be like? Do you want to experience physical or emotional symptoms? As I often say, many people tell me they'd like to wake up dead when they ask how they would like to die. And although I remind them you're not going to wake up if you're dead, that's still somewhere in their idea of what the ideal death is. So think a little bit about where you will be and what you will experience with your ideal death. The only caveat is that there's no way to avoid this process. You're going to die. What does it look like? These are some common themes when people spend time thinking about what they want their death to look like. They want to be at home or at least feel at home. They want to be comfortable. Very few people see suffering as redemptive and therefore want to do a lot of it before they die, although they're the few that see it that way. But in general, they want to have the opportunity to complete their life, to say goodbyes, to review their life, to apologize, to forgive, to complete in whatever way they feel necessary their life. And most of them, when they talk about it, don't want it drawn out. They want it relatively quick. So when we think about some of what the public says, I think we need to look at what do we get. If that's what we want, what happens? The support study, which is the study to understand prognosis and preferences for outcomes and risk of treatment, if that's not a mouthful, I don't know what is, was a study that was done in the 90s to look at end-of-life care with seriously ill hospitalized patients. It was funded by the Robert Wood Johnson Foundation. It consisted of 9,000 patients with life-threatening illness. The first phase looked at how people die in hospitals. And we got a lot of, I think, surprising and maybe even distressing information from that. The second phase really tried to see if we could fix that, and it didn't work so well. So we're still working on trying to fix it. But some of the information that I think is important from that study is, number one, and maybe this isn't surprising, but this certainly identifies that physicians have no way of knowing what your wishes about resuscitation are without having a discussion with you. They were better, just slightly better than guessing. 53%, or worse than guessing, 53% of them couldn't make the same choice that you would make if they hadn't discussed that with you. So in essence, they would guess what your wishes were at the end of life. This is a 67-year-old retired nurse in England who wanted to make sure that her wishes were known and that there would be no mistake about what her wishes were. So she had this tattoo placed on her breast so that everyone would have that information at hand when it was needed. But hopefully there's an easier way to pass along this information, and that's what we'll talk about. We also found that in dying in the United States, that it was not uncommon to have prolonged suffering, 10 or more days in an ICU, in a coma, or on a ventilator. These are very different from what I think most people would wish at the end of life. So distressing that it happens to a fairly large percentage of us. The third thing is that 50% of those dying experienced moderate or severe pain at least half of the time within their last few days of life. And this is the statistic that is most distressing, is how can we place more attention? How can we make sure that their last days of life are not in moderate or severe pain? And so this gave us a lot of information about how we wanted to fix things. The support study also looked at the site of death, and it found out that the site of death was predicted by all of these things: the number of hospital beds, the amount of hospice spending, the percent of patients in nursing homes, the expenditures on long-term care, and the diagnostic category of the patient. What didn't make any difference was what the patient wanted. And I think that's a pretty sad statement of how well we're doing in being able to grant people the end-of-life care that they want. If you look at where you're going to die, if you live in the United States or Texas, this is the most recent data that is available. And the numbers of those us dying in institutions is increasing, even though people overwhelmingly state that they would prefer to be at home when this occurs. And so I guess what I'd like to ask you, if you've had those few minutes to think about what your death should be like, is any of the data I presented consistent with your fantasy death? And I would hesitate to guess that it's not. So what can we do about it? And one of the things that we can do is to look and think both as individuals, as a society, and as professionals about advanced care planning. How can we make sure that our wishes are known, that our wishes are communicated, and that we achieve that balance of what type of interventions we want and those goals that we desire at the end of life? So we're going to talk about advanced care planning. And I think these are all important parts of what you need to understand about advanced care planning. It's planning for future medical care. It's planning for the event, for the period, for the time when you no longer can make your wishes known. So it's not a replacement for asking you. It's a document that is available when you're no longer able to make your own choices. And because of that, because my decisions as a 24-year-old are probably very different from a 42-year-old or a 52-year-old or a 72-year-old, this is not a one-time event. This is something that needs to be revisited, rethought, revised as your life changes, as your disease process changes, as you age, as your responsibilities change, all of those. So we need to think about this and update your planning regularly. It also is an opportunity for you and hopefully your family and those that are important to you to think about values and goals. What kind of quality of life is acceptable to me? And therefore, how can I make choices around that? So it empowers you to really think about that and to put yourself in those situations. It also is very important, and I'll talk about this as we go through it a little later, that for you to think about, if you are unable to make decisions, who can help the professionals make decisions for you? Who is a proxy decision maker? I'll talk about advanced care planning and I'll talk about recording your wishes, but I will promise you that as hard as you think and as much as you try to place yourself in different situations, the complexity of medical care can present you with a situation that you never anticipated. And so it's hard to second guess what all that could happen to you in the future. And so it's important to talk with someone who can be counted on to represent your wishes. And that's why it's so important to have a proxy decision maker appointed. Again, this is a process. It's not a one-time thing. And it is not essential, but it is certainly important that you have documentation. I think the Terry Chavo case presents for it that her wishes were known, but there was a great deal of debate because they weren't written. And so for whatever reasons, our society places a lot of value in written legal documentation. And so you always make the lawyers happy if you have a signed legal document that clearly states these things. So the conversation is essential. The documentation is certainly important, and I would encourage it. It's important to think about goals. Many times when we think about what kind of care we want, we talk about procedures, we talk about treatments, we talk about ventilators, dialysis, blood transfusions, etc., and not what kind of quality of life you have, what kind of values you have about independence, what kind of values and how you think about and define a good life. So those are important to focus on, sometimes more than a procedure that may have different impact depending on the situation it's implied in. It's, again, important that you review things, as I've already emphasized. Changing health status, advancing illness, when you move from your own home to assisted living or a nursing home. Those are all good times to look and review, are my wishes still the same? And so you need to get in the habit of thinking about care planning as an ongoing process. There are 3 documents in Texas that are used for Advance Directive. The first is generically known as a living will. The Directive to Physicians, Family, and Surrogates is its formal name. It's the document in which you agree to or reject life-sustaining treatment in 2 situations, when you're irreversibly ill or when you're in a terminal condition. The second, and I think the most important document, is the medical power of attorney. In this document, you would appoint an agent. You appoint someone who will make decisions for you when you are unable to do so. That agent, that person, can react based on what is going on in that situation, not just yes or no, I do or don't want life-sustaining treatment. But based on this situation, based on what's wrong with me, based on the prognosis, I think that she either would or would not want care. And the third document is the out-of-hospital DNR document that is really utilized to allow emergency medical personnel not to resuscitate you, give you basic cardiac resuscitation in any out-of-hospital setting. And we'll talk about just briefly about these three. The living will, the directive in its formal title, makes treatment choices for, as I said, a patient in a terminal condition, which is defined by the law as we expect this person to die within 6 months. We're not very good at predicting that, but that's as close as we can get. The second category is that of when the patient is in an irreversible condition. And that means the patient has a condition that will eventually be fatal without life-sustaining treatment, but is not necessarily fatal within 6 months or even a year. One of the most common examples of this is Alzheimer's disease, where early Alzheimer's disease is clearly not imminently terminal, but eventually that person will die without life-sustaining treatment. In the Texas document, you can either choose to have life-sustaining treatment or choose not to have. So contrary to the assumption that many people make that if I have an advance directive, that means I don't want care, in fact, in Texas, it can determine that you do want care and that you want all the care we have to offer you. So those are the options that are available for you. And again, they apply only when you qualify according to the law. That means you're either certified to be in a terminal or irreversible condition, and you are able to make that decision for yourself. So those are the two qualifying factors for that. All of these advance directive documents do not require a lawyer or notary. They can be printed off a website. They can be completed around the dinner table. You need to have 2 witnesses. One of those witnesses needs to be someone that's not your health care provider, not a family member, and not going to inherit from you. So it needs to be a next-door neighbor or someone that is kind of outside of the treatment family circle, if you want. It's important as you think about advance directive documents that you don't lock them in your safe deposit box where no one can get them, but that they're easily available. Everyone has a copy, all of your children, anyone who might be called on to be asked questions about what your wishes are. So they need to be very easily accessible. As I've already, I think, emphasized, the medical power of attorney document is the preferable document because it really gives that agent the opportunity to answer questions depending on the clinical situation, which is much better estimation of what your wishes are. It's important as you think about your medical power of attorney that, number one, that you have to talk with that person about what your wishes are. If you appoint someone your medical power of attorney and choose either not to tell that person or not to have a discussion, that person is really not a very good decision maker for you. They have no idea necessarily what your wishes are for treatment. The second thing is there may be members of your family who may be your next of kin, who may not be willing to implement your wishes. If your spouse says, honey, I don't care how sick you are, I could not turn off your ventilator, and you want your ventilator turned off under certain conditions, then your spouse may not be the best person to be your medical power of attorney. It may need to be someone a little farther separated from the situation who can comply with your wishes. So think about those two important factors. The out-of-hospital.
Would that be a
Yes, ma'am?
problem? I mean, legally, if you don't have an advance directive, it's your husband, right, would be
Your spouse is first.
right, to make your decisions. And if you have a piece of paper that says, okay, I want my sister to do it, could that be an argument?
No. As long as the medical power of attorney is completed, witnessed as appropriate, then that is the governing document.
So we can overrun what the spouse wants.
It would override that, absolutely. And it may be important in a situation like that, or in a situation where perhaps a gay couple where they want the partner to be able to make a decision. And in our state, there's no legal recognition for that partner without this document. So this document is important if you want someone other than your next of kin to make decisions for you. Absolutely. The out-of-hospital DNR order applies only to cardiopulmonary resuscitation. Again, as I mentioned, it's to EMS. That's its primary purpose. Although an out-of-hospital setting also includes an emergency room, an outpatient clinic, or a nursing home. So it can be an institution, and in some cases, really a part of a hospital, but it's still identified by the law as an out-of-hospital setting. The out-of-hospital DNR document, this is what it looks like. This document, contrary to the other documents, requires a doctor's signature on it. In addition, there is a bracelet that accompanies it, and the patient can wear. Forms, as everyone knows, have a wonderful way of disappearing when a patient is transported. If a patient is at the mall, they may not have their out-of-hospital DNR tucked in their pocket, and so the bracelet can be used as documentation and as the only required documentation to indicate the patient's wishes. We talk a lot about advance directives, and then we also talk in the hospital setting, at least, about do not resuscitate. And those are very similar, but not the same things. An advance directive, as I've already talked about, is a document that you complete many times outside, totally outside the healthcare setting. It's signed by you and witnesses. And it can apply to anything, any type of medical treatment. You can fill in and say when you want or don't want that treatment. As I've already said, it requires your signature. A do not resuscitate order in an inpatient setting is a physician's order. And it's generally for those people that have a risk of dying during that hospitalization, and for one reason or another, they choose not to be resuscitated. That could be someone who already has a debilitating illness, who already is suffering from chronic or a terminal condition, or it can be someone that just doesn't like the odds of CPR in the hospital setting. If we think too hard about the fact that if we arrest in the hospital, our odds of leaving that hospital after that arrest are less than 15%, CPR doesn't really offer us too much chance to leave the hospital. And if you have another illness on top of that, your chances are lessened even more than that. So there's some who just want to refuse it because they feel it's ineffective. But although there's confusion And certainly we address patients' wishes about CPR. It really is a doctor's order that's written in the hospital and applies only in the hospital setting, unlike the out-of-hospital DNR or any of the other advance directive documents. There are lots of barriers to completion, patient barriers, and I'll just go through all of this. But lots of reasons we don't do them. We don't want to talk about death. We feel that physicians ought to be the ones that start these conversations. We feel like, I don't want to bother with that. Let my family decide. Let it be their issue. If you've ever tried to have a discussion with your family, many of them are upset by the planning process. I don't want to talk about that, period. Not a topic to be discussed. So there's lots of reasons in general that patients don't want to talk about advance directives. There are also reasons that physicians don't want to talk about advance directive. There's no easy way I can tell you this, so I'm sending you to someone who can. So avoidance again. So why don't physicians want to talk about them? Well, they may feel that they'll worry the physicians, worry the patient, so they'd rather the patient bring it up. The patient thinks the physician should bring it up. The physician thinks the patient should, so nobody ever brings it up, and the topic is never addressed. Many physicians lack understanding of advance directives. They feel that it hampers their care. It cuts off some of the available options for them. I've had many physicians tell me that they're just inappropriate. Patients shouldn't really be involved in these decisions. It should all be in their hands. Hopefully that attitude is getting less and less, but every once in a while you will hear. Many of them don't understand advance directives, and they too have a great discomfort with the topic. And this is not a topic that can be discussed in 5 minutes. And so in our very hurried medical practices, it's tough to open up a topic that you know is not going to be finished quickly. And many have negative attitudes in general about it. Again, I'm the physician, let me decide what is best for you in each setting. The other problem deals with prognosis. Mrs. A, depicted here, is a 94-year-old with congestive heart failure, severe peripheral vascular disease, a systolic blood pressure of 100, shortness of breath at rest or with mild exertion. She is treated judiciously with medications. Is this patient terminally ill? It's kind of a difficult question to answer. And so sometimes our laws don't actually work in the clinical setting. And so how do I decide if this patient is terminally ill? Cancer we can predict pretty well. They have a downhill course that looks like this. On the other hand, our 94-year-old patient may have a trajectory that looks like this. And so at which point does she become terminally ill? Which episode, exacerbation, is going to cause her death? It's very hard without a crystal ball to be able to predict which one acute episode is actually going to result on her death. So prognosis can be real difficult. The elephant in the room is from a article that talks about these discussions. It's the issue that's right up there but nobody wants to talk about, and I have these 3 cute elephants, so I have to show them. When is it urgent to talk about it? When someone's clearly dying, whatever the reason is. When any patient is talking about wanting to die. When they start asking questions about hospice or palliative care. When they're hospitalized for a severe progressive illness. and when there's severe suffering that is occurring and the patient's prognosis is not good. Those are really urgent times to talk. Routinely, I think it's a great idea to routinely talk about advance directives as part of your outpatient care when you're discussing any prognosis for any new diagnosis, when you're talking about treatments that don't have a great opportunity for success. Any patient that's talking about their hopes and fears in light of their illness or their present condition. And when the physician starts thinking that rather than I think strongly this person is going to die very soon, instead thinks I wouldn't be surprised if this person died in the next year, is probably a better estimate of those patients that are in the need of a very specific discussion about their wishes and about advanced care planning. And then the other difficult questions that you hear and dread, I believe. Why me? Why didn't you catch this sooner? Was this a mistake? Did someone make a mistake? How long do I have? What would you do if you were in my shoes? If my suffering really gets bad, will you help me die? I think these are all the really tough questions and questions we can't walk away from. How do we foster advanced directive discussions? We make it routine. This is something I discuss with everybody. I'm not picking you out. I talk about it with everybody. We should elicit important values. What makes a life worth living? What makes life not worth living for you? Again, emphasize quality of life, emphasize their values rather than ventilators or blood transfusions. Address a limited number of issues. CPR and certainly artificial nutrition and hydration is an important one. It's important to complete the documents and review and update the documents regularly. Pope John Paul, in March of last year, gave a statement that sent a lot of people in a spin as far as the place of artificial nutrition and hydration in patients' treatment. He stated that basically artificially provided nutrition and hydration was not a medical treatment, and it was, rather than extraordinary care, ordinary care, and was morally obligatory. This is one statement in one speech that is a significant change from previous Catholic tradition for the past 2,000 years, really. So I think we need to be aware of that for our patients that are concerned about this. But I think we need to be open-minded in that there's a lot of debate about what this means. Previous Catholic tradition has always said that patients can balance benefits and burdens, and treatments that are considered of greater burden than benefit do not have to be provided. And so I think we need to be aware of this as healthcare providers, but be open-minded as to how this will really play out with a new pope, with new interpretations, as this statement really is incorporated in present-day theology, if you will. I want to go through the case study quickly, although I know my time is running out, but we're okay, because I think it's important. I'll let you read and just kind of give you a short part of this. I think this case demonstrates some of the issues and problems with Advance Directive. Myrtle Anderson is an elderly woman who's been through her husband's death. Her husband died in the ICU on a ventilator. He spent 6 weeks there. She saw that as not a good thing to do and didn't want to face the same situation. So she filled out a living will and stated she didn't want extraordinary measures to keep her alive if she were terminally ill or permanently unconscious. She locked it in her desk with her will and other important papers. Can anyone see the first mistake that Myrtle made? She locked it up. Did she talk to anybody about it? We don't know that from this case, but it doesn't look like it. So what good does this document do you if it's locked up in your desk and nobody knows about it? The other problem is, although she may have used the Texas document and checked the boxes, that doesn't really give us a whole lot of information about what does it mean to be terminally ill to her. What does it mean to be permanently unconscious? It's lots of people toss around, I don't want to be a vegetable. Well, is that a medical definition? Is that your interpretation? What do you mean by that? And I think probably if we went around the room, each of us may have a little different definition of what being a vegetable means to us. And so it doesn't help us a lot if we don't agree on what those definitions are. Myrtle has a nephew, Tom, that lives in the same city with her and is very fond of her. He went to check on her and found her confused and unable to speak. He called 911 and they admitted her to the hospital. She had a cerebral hemorrhage. They asked Tom, who was the only relative that was around, does she have an advance directive? And he didn't know anything about it. Which is not uncommon. I guess my questions here is, you're the staff in the ER. How do we respond to Myrtle? How aggressively does she want to be treated? We have no idea. So our default is that we're going to aggressively treat her, assuming that she would want treatment and having no knowledge otherwise. Who can make decisions for this woman? Is it Tom because he's there? We would want to look at for her next of kin. It may be Tom. Often people have cousins, nephews, nieces, someone that's sort of removed making those decisions. But first we need to find out, we know her husband's dead. Does she have any children? You know, are her parents living? And look at some of her family members that may be of a higher hierarchy in the law. But in the meantime, Tom may be all we have until we find someone else. So Myrtle is stabilized. And we find out that she does have a daughter that's in North Carolina. Unfortunately, they haven't spoken for several years, which sometimes happens. Carol says she has no idea what her mother would want, and that she really has problems of her own, and she can't worry about her mother right now, which is also a not infrequent answer you sometimes get when you call relatives that are far separated and sometimes estranged. The physicians that are caring for Myrtle in the hospital also call her primary care physician, who says, sorry, we never talked about it. I can offer you no information about what Myrtle's wishes may be. So now, who acts as a surrogate for Mrs. Anderson? Well, we have a daughter who would be a closer next of kin, but she's refused. You can't make somebody make decisions. If there's no one else, then certainly Tom would be an appropriate surrogate. And how does he make decisions? What standard does he use? Does he get to do what he wants? No, he's not power of attorney. He's just the only person we have to make decisions. Well, first of all, the standard of decision making is what her wishes are, which he doesn't know. They've never talked about this. He can only make assumptions. The second standard is try to think from knowing this woman, from knowing her values, what's important to her, and make the decision he thinks she would have made in the situation. And thirdly, if you have no idea what her decision would be, then you try to make the decision that's in her best interest, and how, as much as you can, define her best interest according to her values. Not necessarily yours, but hers. All of us, as a family member making decisions, don't want to lose our loved one. But that shouldn't be the primary decision. That shouldn't be the primary influence on our decision. But yet, what is in this patient's best interest at this point in time. So let's go on. Myrtle gets better. She has some problems, but she is transferred to a SNF for rehab. When she's admitted to the SNF, they ask her if she has an advance directive, and she emphatically tells them, yes, locked up in my drawer. So Tom agrees to look for the directive at her home and finds her living will. He brings it in, and the physician asks if this is the document she means to govern her care. This document does not designate an agent, but she does indicate she wants it to influence her care. And when she asks about resuscitation, Myrtle very emphatically says she does not want to be resuscitated if she arrests or stops breathing. So we have that information. Advance directives do not necessarily mean the patient doesn't want to be resuscitated. And even though Myrtle has an advance directive, if she is awake and able to answer questions and understand, then her decision should be the one we go with at that point in time. We don't just pull the advance directive out and say, she says in this, and ignore what the patient currently wants at this time. So, but we have asked Myrtle, and she has said that she wants to be DNR. Otherwise, we would have to wait for the point in time and decide, is she terminal or irreversible, and is she unable to make decisions at that time? The physician was really good. She recognized and documented that Myrtle not only had decision-making capacity, but that she agreed to forego resuscitation, and so she entered that in her chart. She also filled out an out-of-hospital DNR form so that it would be available the next time Myrtle had to go travel to the ER, travel to an outpatient clinic, travel somewhere for any reason. And the nurse signed as a witness to Myrtle's mark on this document. You have a question?
Well, kind of. If the patient had the out-of-hospital DNR, was in the nursing home, does that indicate to the nursing home that, or only in the event should she stop breathing and her heart stops, that they call EMS, that anything else is okay to send her to the emergency?
I think that's the other part of the discussion you need to have. When a patient says they want to be DNR, the answer to that question is really, if my heart stops and my breathing stops, do I want you to do CPR? And that's really that's only part of the question. The other question is, if anything less than that happens, what kind of care do I want? And I think you need to have discussions about patients about how aggressive do you want us to be? How certain do we need to be about the reversibility of your disease? Many patients are willing to go on a ventilator for 3 or 4 days, but not for 3 or 4 weeks. And sometimes we can predict that and at least give them a clue of which answer they're making. And so we need to discuss those issues. In this case, she has both a written DNR order, which applies in her SNF, and then she also has the out-of-hospital DNR form. Can the nurse act as a witness?
Well, you said yes, but on one.
Yes, she can be one of the witnesses. She is not a qualified witness because she's caring for Myrtle, but she can be one of the two witnesses. We need to get a qualified witness as the other one, someone that's not caring for her, is not related to her, and is not going to inherit from her.
But can it be another employee?
Mm-hmm.
Like a housekeeper or something?
Sure. Yeah, ward clerk sometimes will do it in the hospital setting.
Yes.
Somebody from another floor, that sort.
Another social worker not working on that case?
Yes, absolutely. Yes, ma'am.
Not qualified.
Yes, I have a question. My husband died 3 years ago with leukemia. And when he died, they told me that he had passed away. First thing I asked them, did they do CPR? And they said no. I said, well, why didn't you? They pulled out the book on that he already signed his DNA. I couldn't have override that.
Could you have overridden that? Not if he made the decision at a time when he was able?
Yeah, we never discussed it, but he must have wanted me to know about it. He had signed all his paperwork and everything for everything. When he passed away, I didn't have to do anything because he had everything taken care of.
Well, he wanted to spare you that
He did,
decision.
and
Yeah.
I thank God for that.
Yeah, and yes, so if you have it from the patient, a family member shouldn't really be overruling that. Sometimes we'll debate about that, and sometimes we'll do different things. But in general, the patient's decision should be the one that yeah. I want to keep going on the case, and then we may have a minute or two for questions. Myrtle got better. Her rehab was successful, and she had some problems. Afterwards, she developed shortness of breath and chest pain, and she went back to the hospital. The SNF transferred the advance directive documents with her and made sure the EMTs were aware of out-of-hospital DNR form. Again, Myrtle hadn't refused care. She just, if you got sick enough that you were arrested, she didn't want that she didn't want to be resuscitated at that point. So when she got there, they reviewed this. In addition, when she got to the hospital, they asked specifically about who should make decisions for her. And at that time, she said, I want Tom to make decisions. So they went ahead and completed the appropriate documents, either a medical power of attorney or a note that was in the chart. And
Which is adequate?
which is adequate, yes.
Documenting that the patient selected this person to be her medical power.
And that would be an oral appointment, and that could be documented with two witnesses in the chart. In this case, Myrtle can sign, so it would be better to do a legal document that's more easily transported. If it's buried in a progress note, the chance of it getting to any place else, next hospitalization or any place else, is a problem. It's legally adequate, it's just not easily transported. So anyway, the doctor, when Myrtle said this, she suggested, you really ought to talk to Tom about this, and you ought to tell your daughter about it. Myrtle did well and went back to the SNF. Unfortunately, she decided not really to talk with her daughter about the appointment of Tom, although she went ahead and completed all the paperwork. So Tom was officially appointed as her medical power of attorney, and everyone knew it at the nursing home. But out of the blue, here comes Carol, her daughter, to visit, not knowing that she has been replaced in the medical decision-making hierarchy, if you will. And because things were going so well, Myrtle just really didn't want to muddy the waters, so she didn't tell Carol. Unfortunately, Myrtle had another stroke, and this time it was a devastating stroke. In the emergency room, everyone looked to Tom for decisions. Carol really couldn't understand why this was happening, and didn't necessarily agree with her, with the decisions Tom was making. And so she kind of raised a ruckus. She wanted to know why they were letting him make decisions, why they were letting Tom murder her mother, and she threatened to sue everyone. So you're the person in the ER. What are you going to do about this? You're in a tough spot, and you have to take Carol and talk to her about the appointment of Tom, the fact that Tom is complying with her mother's wishes, and that he is in fact the legal decision maker. Tom and the medical staff prevailed, and Myrtle died without the utilization of life-sustaining treatment as she wished. Myrtle had made funeral arrangements years before when her husband died. Carol had been named as the person in charge of the arrangements. And although Carol didn't necessarily like what happened, there was no legal outcome from this. And even if there were to be, the documents were appropriate, and the staff did what they could and should in these situations. But I think this little scenario tells us of perhaps some of the difficulties of really putting advance directives into practice, all of which would be cured by communication. Good communication in all situations, which I will encourage. Just quickly, dying is part of living. We need to approach it openly. We need to change our society so we can talk about it. Advance directives are important. They are helpful to both the patients and those who are making decisions based on what the patient wants. When illness is incurable and death is inevitable, goals may shift from cure to palliation. And our next speaker will talk to us a little more about this shift. Setting clear goals helps everyone. Avoids confusion and conflict at the end of life, which is devastating to everyone involved. This is a statement by Dr. Cass about the patient's good, and I'll leave you with this thought. If medicine takes aim at death prevention rather than at health and relief of suffering, if it regards every death as premature and as a failure of today's medicine, but avoidable by tomorrow's, then it is tacitly asserting that its true goal is bodily immortality. Physicians should try to keep their eyes on the main business, restoring and correcting what can be corrected and restored, always acknowledging that death will and must come, that health is a mortal good, and that as embodied beings, we are fragile beings that must stop sooner or later, medicine or no medicine. Thank you very much for your attention, and sorry if I went over time. Thank you.
I have suppose someone has a living will in a different state. Could it be applied?
Living wills are pretty transportable. Some states have laws that differ, and generally your living will apply according to the rules of that state. For example, some states require you to have written refusal of artificial fluid nutrition. So in that case, if you went to a state that required that, they may not comply with it if you didn't specifically write that in your advance directive. But generally, they're transportable. Yes, ma'am?
I get uncomfortable with situations where a person who is terminally ill has not wanted to sign an out-of-hospital do not resuscitate order because they want resuscitation. And I work for a hospice, and you know, inevitably they become incapacitated to the extent that they can't make decisions anymore, but the family member is perfectly okay with no CPR. And that has never set well real ethically with me. So what would be your comments on that?
I think that as a patient approaches death, particularly in the situation that you're talking about, many patients may fear that if they sign a DNR, that they're not going to be cared for. And I think we need to very carefully delineate for them that it means that if you die, we will not try to reverse that. Short of that, we're going to care for you and do everything we can to make you comfortable. So I think to some extent it's a process of discussion. And I think also asking, okay, if you're not ready for that, can you tell me when you're going to be ready for it? And I think the other thing is, if you look, most people believe that, you know, we flip a switch on the wall and restart their hearts. They don't realize the extreme unlikelihood of that happening, particularly when they already have a terminal or debilitating illness. So I think it's a process of communication. As far as your ethical responsibility for switching those around, we need to comply with the patient's wishes, but I think when the situation changes, and in the situation you're talking about, the situation has worsened. You've gone from a capacitated patient to one who no longer is. And I think, yes, we need to comply with the patient's wishes as much as we can, but at some point in time, we still need to make decisions based on changes, and that's what the surrogate does for us. And sometimes that's going to include a change in that order.
So I think it's really very important that when people talk about DNR to patients, that they define when DNR really takes effect, that it's only in the event of cardiac arrest or respiratory arrest, because sometimes, I mean, even nurses, you know, it's like DNR is, that's it.
Their DNR, that means we're not going to give them antibiotics, or we're not going to give them a blood transfusion, even if that blood transfusion may help them feel better. You know, so you're exactly right. We need to separate those a little bit and not make them make huge assumptions about what a patient does or doesn't want just because they don't want resuscitation. Exactly. Good point.
That's discussed with the patient at the time of the discussion about DNR. Instead of calling it DNR, some places call it level of care, and they talk about level 3 is where the women's be resuscitated, respiratory or cardiac. Level 2 is antibiotics and whatever.
Yeah, and that's what we've done in our own institution. We have two separate categories. We ask them about resuscitation if they arrest, and then we ask them, other than that, if you're anywhere better than dead, what do you want us to do for you? Comfort care, aggressive care, you know, and try to categorize that. Some other ways they deal with that is they don't talk about do not resuscitate. They talk about allow natural death, or they do not attempt resuscitation. They some way change what we call it in the hopes of making it better understood, rather than something we don't give, something that we allow to happen.
I think a lot of times it's the terminology we use. If we called it artificial nutrition instead of feeding it would have a different connotation.
Absolutely. Our language is extremely important in all of these cases.
We have a couple of other sites that might want to join in with some questions. Are there any questions over at SFA? Top right corner? You can take your mute off and have a question or a comment if you like.
Okay, perhaps I missed this. What about a situation where a patient has no documents, no advance directive, nothing? What do you do? How do you deal with that situation?
And the patient is unable to make any decisions, or you're unable to ask the patient?
In all those situations, not able to answer, no information.
Okay, then you go with the surrogate, whoever the appropriate decision maker is, whether that be a spouse, whether that be an adult child, whether that be a parent. Those are the people we go to, just like we do any other time, to ask those questions. It's important to phrase those questions in a way that we're trying to get to the patient's choice. Talk to them about, you know, if your wife were awake and able to tell us what treatment she wants, considering what has happened, what would she tell us, instead of saying, what do you want us to do for your wife? But try to phrase the question to get the answer the patient would have given us. But basically, the surrogate makes that decision. They're the best representative we have of the patient's wishes. legal documents notwithstanding. If there's no legal documents, then we go back to who can give us consent. That help?
Right.
Thank you, Peter. Those topics to be at SFA. What about anybody else at SFA? Okay, Lamar, any questions or comments for Dr. Bayan? Okay.
All right.
Thank you very much.
Thank you very much. Appreciate your